Connected now?
Yes, it's connected. I can see it now. All right.
Okay.
Hello, sir. Good
Yes,
afternoon.
I can hear you.
Okay, great. All right. Thank you. So I'm just going to let others know that we've started the live and we'll start in a couple of minutes. So just going to put you on mute. Um, every other thing is okay to access, right, from your end.
What did you say?
I'm asking if every other thing is okay to be accessed from your end. Are you okay
Um,
with?
okay, but sharing my screen, I've not used StreamYard before. I thought it
Mhm.
was going to be either Zoom or Google Meet. But
Okay.
okay, how I'm going to do to share my screen? Okay, I've seen somewhere there. Share screen,
Okay.
um, entire screen. Is this appearing there?
It will. Let me check. Hello, everyone. Good afternoon. Good afternoon. Good afternoon. Good afternoon. Thank you so much for joining. I see that we have a few people on already. Thank you so much for joining. We're just gonna wait for others to join in, and we will kickstart almost immediately. I already see a comment. I like the energy, and I see Francis. He says the memory of Agatha Valentine will stand forever. Absolutely. Thank you so much, sir. Okay, so and yes, we have our executive director joining us also on this session. Thank you so much, Ma, for taking our time to be here. We also have our speaker on standby, and thank you so much, sir, for joining in. We're just going to give a few minutes for others to be able to join in on the live. I see just a few people. Whilst we're waiting for others to join in, please, in the comments, feel free to tell us where you're joining us from, your name, and where you're joining us from, and maybe use a food to describe how you feel today. I would love to see that in the comments. Keep it coming so we know that you're with us on this. Thank you. Whilst we wait for others to join in. Is it better? Can you hear me now? I suppose you can. So I'm just saying thank you to Hannah Emmanuel. She's from Abuja. Thank you so much for joining us. I also see Sule Jemima. Thank you so much as well. She says she feels Indomie. Glad to hear that. Thank you so much. We also see Mary from Nasarawa. And we see as well. Okay, can you hear me now? Can you hear me? I see Adeline from Abuja. Thank you so much. Thank you, thank you, thank you, thank you. All right. Can everyone hear me now? Can you all hear me? Can you hear me now? Please confirm that you can hear me. All right. Thank you so much. We're back in track. So someone says they can hear me. So, all right. Thank you. Good afternoon, everybody. Thank you so much. Good afternoon, good morning, good evening, depending on the time you're joining us for this very important program. We're delighted to have you join us for this program. And my name is Grace Udie, and I'm honored to serve as the moderator for today's inaugural webinar by Agatha Valentine Hope Foundation. Oh, I see Gloria from Lafayette also joining us. Thank you so much. So today's webinar is titled Living with Fibroids: What Every Woman Needs to Know. It is designed to educate, to enlighten, to create meaningful conversations around living with fibroids and reproductive health generally. And you would be so amazed to listen to who we have on board to speak to us on this particular topic. So I can't wait to have him speak to us. And I know that you're also anticipating the session where he speaks to us. But before we go to that, I'll just give us a little bit of background, or rather a little bit of statistics on women who are, currently facing fibroid cases. In Nigeria, we have an estimated 20 to 50% of women with of reproductive age who are affected, yet awareness and access to proper care remains limited. So you see why we're having this conversation today. You see why it's important for us to be talking about this. So, not to take so much of our time, and we've already spent a lot of time waiting for others to join in. So we're going to proceed to specially acknowledge the vision, the leadership behind this initiative, and commend the founder of AVHF for transforming a personal loss into a platform of hope, advocacy, and support for women all over the world. So we're truly inspired by his commitment, and we would love for this to be put out there. If you know you're not following our handles already, please, the handles will be in the comment section. Please endeavor to follow our pages, follow what we do so that you can be up to date with activities and programs. Having said this, at this point, just permit me to please invite the Executive Director of Agatha Valentine Hope Foundation to officially welcome us to this session and share more about the organization and the significance of today's webinar. So the floor is all yours. Thank you, ma'am.
Thank you so much, Grace. I hope you all can hear me. Can you all hear me? If you can hear me, please give me a favorite emoji. A thumbs up, a love emoji, if you can hear me. Hello, can you hear me? Okay, I think I can see David Gloria saying that yes, she can hear me. All right. Thank you so much. Thank you, Grace, for that lovely introduction. It's a beautiful afternoon, Friday afternoon. We are already on the time gods, it's Friday mode, but we are here gathered to have to get information, which is one of the most important things that we are about at Agatha Valentine Hope Foundation. So, on behalf of the foundation, the founder, and the entire board of trustees, I'd like to warmly welcome every one of you to our first, and I like to say our inaugural webinar. So the theme is Living with Fibroids: What Every Woman Needs to Know. This is born out of, it was born out of grief, but it is coming out to be, we are coming out to ensure that in the name of late Mrs. Agatha Valentine Hope actually gets to live forever. So my name is Etim Bukikbem, and I serve as executive director for this great foundation. First of all, I want to say that you are here not because of a mistake. You are here because it's either you're here because you live with fibroids, or you know someone who does, or maybe you work in the healthcare space, or simply you just want to learn more. And we are very, very grateful that you have actually joined us. Hello, there's some music in the background. Okay, thank you for that. All right, so tonight actually marks a beginning of a movement. This is our first webinar, a movement that is focused on awareness, is focused on access, is focused on education, is focused on support and advocacy for women's reproductive health in Nigeria. And we will be beginning with fibroid. So AVHF, as it's generally known, the acronym for Agatha Valentine Hope Foundation, was established in honor of late Mrs. Agatha Valentine, who died last year. Yes, it was a tragic loss from complications related to fibroid surgery. However, her passing has actually opened our eyes to the reality that women are actually facing silently. You're talking about delayed diagnoses, you're talking about lack of accurate information, you're talking about financial barriers to treatment, fear and stigma, misinformation, and limited access to quality care. And that's what AVHF is setting out to do. We believe that no woman should lose her life, her dignity, or her future simply because she could not access the right healthcare support at the right time. That belief is what has actually given birth to this foundation. So we have a host of focus areas that we are focused on, thematic areas we are focused on, and one of it is the health education and awareness, which this webinar is an example of one. It's a core area in under this particular pillar. So we'll be having webinars, we'll be having outreaches, we'll be having awareness campaigns, school engagements, to be able to reach people and provide them the right information around fibroid and other reproductive health issues. And though we are also going to be having the fibroid support and access to care. So we are going to be ensuring that we see our women as a major priority, right, to help them to navigate the quality healthcare services in Nigeria, wherever it is that they're located. And we are currently working towards ensuring that we build a trusted referral network of hospitals and specialists, partnerships with medical institutions, and support systems that connect women to verified care providers. We understand how overwhelming the journey can feel alone, and we intend to build a community that can actually support that. And not even to talk about, one of the things that's really very much close to my heart is the Agatha Women's Health Access Fund, which will be launching soon. It's actually, this initiative is supposed to support women with financial assistance to be able to afford diagnosis, scans, medications, and surgical procedures. So you see that it is we have our plans cut out at Agatha Valentine Foundation. But however, we can't do this alone. We need all the support we can get. We need all the support in various ways, from donations to volunteering, and also just ensuring that you get to share our initiatives with various people. So feel free to stay back on the community that we have already started building. Ensure that you follow us on all our social media pages, engaging with our posts, as we will be providing you with information on all these programmatic and thematic areas that I've actually mentioned as it goes. So every month we'll be having series of events geared towards helping women to be able to overcome issues surrounding fibroid and other reproductive health. So I want to say thank you to everyone who has supported, everyone who is here. You are all amazing. And special thanks to our speaker, who we're going to be hearing from very soon. So thank you for believing in this vision. I'll be back sometime, maybe after the speaker is done. But I'd like to say that you are valued here. So feel free to reach out to us at any point in time, and we will provide the support that we need to the best of our abilities. So here on out, I'll just hand this over to our moderator to introduce the speaker. Thank you, and welcome again to this webinar.
Thank you so much, Ma, for welcoming us to this webinar. It was really incredible listening to you speak about, the vision and the mission and the focal point for AVHF. Basically, I hear you say we will prioritize women's issues, and that is something incredible, something to look out for. Thank you so much. We appreciate the incredible work that the foundation is doing to improve reproductive healthcare awareness and support for women's issues. So, permit me now to introduce our speaker for today. I want to see all your favorite emojis on the comments. Let's see that you're happy to listen to our incredible speaker for today. I will not introduce if we do not hear or see you dropping those emojis, please. Let's do that. Let's do that. So I know you're with me. Hmm. Keep them coming. Thank you. Thank you. Thank you so much. Thank you. Yes, keep them coming. All right, I've gotten at least three, so I'm just going to introduce our speaker for today. Our speaker, just permit me to introduce his background a little bit. Our speaker is Dr. Idoreyin Udo. He is a consultant obstetrician and a gynecologist who obtained his MBBS degree from the University of Ibadan in 1990. He completed his postgraduate training at the University College Hospital, Ibadan, and earned the fellowship of the West African College of Surgeons in obstetrics rather, I beg your pardon, and gynecology in 2007. He has earned so many accolades. He has a lot of certifications. If I go on to read this now, we're going to take a lot of time. But please do well to follow his pages as well, so that you can get acquainted to what he does. And also through our pages, you would also see what he does as well. So let me go ahead to give him the floor to kick off this engagement for today. I see a lot of comments. I know you're excited, and this is going to be thrilling. So I encourage us to sit tight, open our hearts and minds to listen and absorb, so that you can gain a lot from this session. So thank you so much, Doctor. Over to you. I'm just going to let him speak now. Doctor, you can unmute yourself.
Okay, can you hear me?
Yes, loud and clear. I can hear you, and I believe the rest can
Okay.
hear you as well.
Yes, good day, everyone. I'd like to welcome you all to this presentation. Um, I first of all would like to thank the Agatha Valentine Hope Foundation, for what and to support what they're doing. Thank them for choosing me probably as one of the first in this webinar to do this presentation. I acknowledge and I want to support the vision and objectives. I also would like to recognize my friend Dr. Daniel Ogut, who in Glasgow recommended, or would I say, recommended me to the foundation for this presentation. As had been said before, I am Dr. Adrian Udo, and I have my own clinic also while working at the teaching hospital. My prayer is at the end of this presentation, I would advance the objectives or visions of Agatha Foundation and hope I'll be able to make impact to the audience. It's always a privilege for me being a man, but whenever we talk about advancing the interests of women, it's a privilege for me to be part of that, and there's a high sense of fulfillment. Today, I'll be talking on, let me try and share my screen. And can everyone see this? Please, can I get some remarks? Can you see this?
No, we can't see it yet. I'm trying to add it to the page. Just give me a minute.
I'm sharing my screen now.
No, it's not up yet.
Is it from my end?
I think so.
Is it from my end?
I believe so, Doc. But just go ahead. Let me see how I can get that up here.
Because I'm sharing the slide. I want to share my PowerPoint.
Okay.
Can this be
No,
seen?
we can't access it yet.
What can be the issue? What's the way forward?
Okay, so just go ahead with your presentation, and I'll see to it at the back end that we upload the video or the slides rather.
Okay, well, let me start. Within the time frame given to me, I would like, I'll be speaking on living with uterine fibroids. Just a few seconds. Let me see. Let me see. Okay, I was trying to set my time so that I'll keep myself within the time frame. Yes, start. Living with fibroids, what every woman needs to know. Unfortunately, my screen is not being observed yet, but what I have here on my outline to share will be the introduction, incidence, the cause of fibroid, if there is, the risk factors, and the different classifications of uterine fibroids, the symptoms that women with fibroids have, diagnosing uterine fibroids, the treatment complications, and having a look at the harmful traditional practices as a result of the myths and the misconceptions people have, and the conclusion. As a matter of introduction, what are fibroids? Fibroids are non-cancerous growths in the muscle layer of the uterus, and that is the womb. And only women have the womb. So they will say it's a peculiar condition that afflicts women because women are the ones that have wombs. They are very common. They are common conditions. They come by other names besides fibroids as myomas, leiomyomas, or fibromyomas. And these fibroids may vary in size. They may be as small as a bean seed, or they may grow to the size or even beyond the watermelon. It is possible to have just one fibroid tumor, or there might be multiple, many fibroids. There are different types of fibroids based on where they grow in the uterus. Um, my my screen is my screen seen?
No, we
Hello.
can't see. We can only see. So please, maybe you could turn on your camera as well, so we can see from your end.
My camera is on.
Oh,
My
it
ca-
is.
my camera is on.
We can't see you from our end.
What about this? There must be something, I don't know.
Is there something else you're trying to share? Is there something else you're sharing right now? Because I can't see it.
Select tab to, let me look at this.
Okay.
What is appearing on that side? You got me in.
I can only see a blank screen from your end. No, no picture, no video.
Allow it, never.
Maybe you
Oh,
could put off the camera and put it on again. Let's see if.
it will not be nice if we can also. I have here choose what you want to share with streamyard.com, and
Mm-hmm.
the options are Chrome tab, window, and entire screen.
Okay. You can
So,
pick not the entire screen, just that window you're working on. What you want
okay,
to share.
anything there?
No, it hasn't popped up.
But I wish Okay, I'll do it this way. Let me use my, well, if I use my phone,
I think you can still share on your phone, sir.
okay, okay, it's all right. That will take just,
Just a minute. All right, sir.
yes, on WhatsApp, then I share my screen on WhatsApp.
Okay.
Okay, please, a few seconds for that.
All right. I apologize for the technical issues. I think we can see Doctor's screen now, and it's up. Doctor, can you hear me?
Yes, I can hear you.
Okay, I see it now. So please go ahead with your presentation. Thank you.
Do I need to refresh? Can you see that? Can you see
Yes,
this?
I can. I can see your screen. I can see your screen. Let's see if others
Can you read
can.
what's
Yes.
there?
Fibroids are non-cancerous growths in the muscle layer of the
Okay,
uterus.
okay. Thank you. I'm sorry for that glitch. Yes, I was at the stage of saying that there are different types of fibroids based on where they are in the uterus. So here we have two images, and we can see that the fibroids can be anywhere on the outer wall of the uterus, can be within the walls of the uterus, and in the lower part of the uterus. Take, for instance, the other image on my left is actually one of the patients I operated on. So it's not like, I mean, besides what's in the textbook, it's very common. And I did that operation myself. And looking at, like I said, they can be as big as watermelon, or if not larger. And here is a small one. And I did say that you can have multiples of fibroids within the uterus. If you see the ruler on the right there, it's about 15 centimeters. If you look at the smallest fibroid there, you'll see it's probably less than 1 centimeter. So, talking about the incidence, it is said that through studies, 70 to 80% of persons, of women with the uterus, are affected during their lifetime. But most patients who have this diagnosis were not previously aware that they had this, and that is to about a percentage of 50 to 72%, which shows that most women that have fibroids are not even aware they have these fibroids, even though they are very common. The age distribution, it peaks between 30 to 50 years, and uterine fibroids are said to be the most common pelvic tumors. The incidence of fibroids, it increases with age until menopause. And we'll see later on why after attaining menopause, the fibroids may tend to reduce in size. This condition is also higher in blacks than in whites. And depending on the studies, some say about 2 times, some say up to 9 times commoner in Afro Americans than the non African population. Um, and of course, it's also known that black persons have a higher disease burden overall than whites. So, what is the cause of uterine fibroid? It is largely unknown. But what is known is that the female hormones, estrogen and progesterone, have been linked to the growth of uterine fibroids. That is why when a woman attains menopause, which is related to reduction of these hormones, fibroids also stop growing. They don't disappear, but they stop growing when a woman attains menopause. So that's what they may shrink after menopause. It's also been observed that there is some kind of link with the family history, that there is a genetic predisposition, and if one person has, there may be or there is a tendency for other members of the family to have it. What are the risk factors? I've already said that the black women amongst the races, the blacks have the highest incidence, and about 2 to 9 times more than white women in the African Americans compared with the white women. This condition is also, it appears to be much more common in women who have never put to bed. That's what I mean by nulliparity. Women who have never given birth are at higher risk. Women with increased body mass index is associated with having fibroids. Oral contraceptive pills, the estrogen, the progesterone pills. Women that take this, it appears these pills, especially when they take it for a long time, it may appear to be protective in the development of against the development of fibroids. I have said before that there appears there is some genetic predisposition which with an increased risk in the family history. Women having regular exercise are at lower risk to having uterine fibroids. It is said that diet and lifestyle also have their impact to the predisposition to having this. And red meat and ham have been known to increase the risk, whereas leafy vegetables and regular exercise appear to be protective. Someone might say, well, but Africans, especially in the remote areas, may not take as much red meat as the whites, considering their socioeconomic status. Why is it more common? But then you realize that over the last few decades, the incidence has increased, and even among younger women, and probably because of that will be related to the lifestyle and dietary change compared to 30, 40 years ago, how many people could afford meat? But then the basic underlying thing is that this condition is commoner amongst the Black women. Let's look at the classification. I had shown this image before. Towards the outer outline of the uterus, we'll say that like this is subserous. And when it's attached to a stalk, you'll say it's pedunculated subserous. All of these have their different symptoms depending on where the fibroid is. Now, when it is in between the layers of the uterus, it is said to be intramural. And this area lining the inner surface of the womb is where menstruation occurs. And fibroids lying close to this surface are said to be submucous. And the fibroid here, which is in the cervical part of the uterus has two parts. This is the body and this is the cervix. So just as well as it can occur in the body, it can also occur in the cervix. The ones that develop in the intramural ones, the ones that develop within the walls, those are the most common, but the most problematic, they produce the severe symptoms, though they may not be so common, are those ones, the submucous ones, which I did mention, are these ones that lie close to this surface, because this is where menstruation occurs. So you'll understand why the symptoms that are associated with this. Now, when looked at it in the lab, what would be observed? The gross findings. Fibroids are frequently multiple and not occasionally, very rare though, it may just be one singular fibroid, but more frequently they're multiple. Like I said before, they may be seen as tiny seeds or they may be very, very large. They're usually firm in consistency, may assume any shape, especially when they are larger, they appear to be spherical and oval shaped. When looked at under the microscope, fibroids consist of two types of tissues, smooth muscles and fibrous tissue mixed together in different proportions. And fibroids undergo some changes, but a few of them are of concern, especially this one, the red degeneration. For women that have fibroids in pregnancy, they may have very excruciating pain when the fibroid in pregnancy undergoes this degeneration. And that is probably as a result of when the fibroid, there's something, maybe it's outlives his blood supply, this could be very severe, and sometimes it has confused and led people to thinking that the woman is in labor. There are other types, the hyaline, the calcific changes. The septic degeneration usually occurs probably after the woman has put to bed, an infection may set in. Even though it is very rare, but it is not unusual that very rarely cancerous change, what we say sarcomatous change, may occur within the fibroid. Now let's look at the symptoms. Most fibroids are asymptomatic. By that, I mean most women that have fibroids may not know, they may not be aware that they have symptoms. But when there are symptoms, these are things that occur. They're usually menstrual irregularities, especially when the fibroid is closed, like I had showed earlier, is close to the inner lining, the inner surface of the uterus. One of the greatest presentations of most concern is heavy period. The woman may be having heavy periods so that instead of using 2 to 3 pads per day, she probably would use much more than 4 to 5 pads per day. And just an interjection here. If you remember the woman in the story of the Bible, that the woman that had the issue of blood, I sometimes wonder because it will not tell us the name, but I have I have a feeling this woman might have had something like this. I'm saying. So women may present with heavy bleeding. It's not just that the bleeding may be heavy, sometimes it may be prolonged, and there might be bleeding in between periods. Now, when there is significant, consistent, and heavy bleeding, it may cause significant blood loss, that the blood level in the body may drop, and the woman may have what is called anemia. And anemia has its own associated symptoms. Other symptoms may be like periodic pain, menstrual pain, when women complain of menstrual pain. Now, menstrual pain has several causes. Uterine fibroid is one of the causes of, not to mention that every menstrual pain is caused by fibroid, no, but it's one of the causes. When the fibroid has grown very large, there might be swelling, an obvious abdominal swelling. The woman herself may notice that she has abdominal swelling. She may sometimes feel a hard mass in the lower abdomen. And of course, as the fibroid gets larger, she may begin to feel some pain or pressure symptoms, something like weighing her down in the lower abdomen, which may also cause lower back pain. She may have painful sex, and because of the mass, especially the enlarged ones that occupy the space in the abdomen, there's little space for the bladder to collect urine and store till when the individual probably feels comfortable. Instead, what may happen is she may have the urge to wee very frequently. There might be constipation because the enlarged mass is pressing on the rectum. You know, the rectum is probably one of the last parts of the intestines before it gets into the anus. So when there's a mass there, it could be impinging on the rectum, reducing the capacity and the ability for feces to flow naturally to the anus. Now, owing to this stigma, discussing menstruation with many people might not, as part of the culture, not many women may discuss menstrual irregularities. And sometimes it might even be because they are unaware. Like I had said before, a woman that might have had some form of symptoms earlier, probably at menopause, might observe regression of the symptoms because at menopause, there should be regression of those symptoms, maybe bleeding. Of course, if the woman is not seeing her flow, it's a plus for her, meaning that she will not lose blood again. But it also depends. If there was significant abdominal swelling, there might be a slight reduction or the symptoms will reduce. Now, like I said, because of bleeding, especially if it's significant, the woman may develop pallor. which is a sign of anemia. And besides the woman herself observing that the abdomen is swelling, when we examine patients, we may observe that there is lower abdominal swelling, which, depending on the size of the fibroid, the woman herself may not have known. Now, as a result of enlarged abdomen, it may bring about confusion. People may not know the woman has fibroid. They may think it's pregnancy. Some might think it might mimic ovarian tumor, and all of these things I have listed here. How do we diagnose uterine fibroid? The most effective method, cost effective, and the most widely available is the ultrasound scan, which can be abdominal, pelvic, or transvaginal. But there are other modalities for diagnosing uterine fibroids. It's just that it is not specifically for fibroid. Maybe there's additional information one wants to get. Take, for instance, MRI. This can be useful, especially if one needs to make a distinction between ordinary fibroid and the cancerous kind of fibroid. Then, this may be observed probably in the course of evaluating patients for infertility, like hysteroscopy and laparoscopy. But we would not traditionally send patients for all of this. The commonest, cost-effective, and method is the ultrasound scan. Treatment. We only treat women with fibroids that are symptomatic are those ones that should be treated. Otherwise, why would you want to, like they say, let sleeping dogs lie? If a woman has tiny fibroids through scan and it's not causing any discomfort, pain, why would you want to trouble the fibroid? And it's not every fibroid that poses danger or threat to the body. So only fibroids that are symptomatic that are usually treated. And therefore, if treatment is recommended, it depends on a number of variables and factors. First, looking at symptoms, she must have significant symptoms like bleeding. What about the location? Usually we know that the problematic ones are usually the submucous fibroids. Those ones, irrespective of size, whether it is small, whether it is large, once there is a submucous fibroid, these are the ones that will produce severe bleeding and will constitute or interfere with fertility. The size and the number of fibroids will determine the kind of treatment, whether medical or surgical. The age of the woman, it's very important because if a woman comes at the age of 30, married or unmarried, it's different from a woman that comes to see the doctor at 45 to 50, married or unmarried. And above all, one of the things, especially when surgery is considered in treating fibroids, is what is the fertility desire of that woman? Has she completed her family size or is she still desirous of pregnancy? There are several different types of treatment. Your treatment options can be medical or it can be surgical. Medical options are usually temporary measures administered to reduce or control symptoms, while the patient is on medications, usually to buy time till surgery is done. Surgery is the definitive treatment. But sometimes there are conditions that militate against surgery. So there are medications that can be given strictly to treat the symptoms, but they will not take out the fibroids and may temporarily reduce the size of the fibroids. But the issue with medical condition therapy is once the medication stops, within a short period of time, the tumor starts going again and the symptoms return. So medical management is one option, surgical management is the other option. Surgery can be to take out the fibroids, take out the womb, or a procedure to shrink, reduce the size of the fibroid. Here we are, there are three. It might be removal of the fibroid. When taking decisions for surgery, like I earlier highlighted, one of the things might be what is the woman's desire for fertility. That will go a long way in determining what type of surgery the woman would want to have. Because if woman is desirous of having pregnancy, even when she might be within 40 to 50, there is still hope and there is room that even if she might not use her eggs to get pregnant, she can still be the mother. She has a womb. She may still want to carry the baby. So these are things that would help determine, even when the patient is having will be recommended or counseled for surgery, her fertility desire still counts a lot. So under surgery, what is it that will be the target? Is it to remove the fibroids, or will it be to remove the whole of the uterus, which is the definitive treatment, and it takes care of the present and future probability of developing a fibroid? Then there are others. Let's get back to the medical treatment. Like I said before, the medical treatment is aimed at reducing symptoms. They may shrink the fibroids and treat the symptoms to stop bleeding, reduce pain. In this group are medications such as, I'll mention the classes. I mean, I don't expect to mention the names of the drugs here. I wouldn't advise self-medication. But the classes of drugs used are the oral contraceptive pills. There are drugs that come under what is called the GnRH agonist. I mean, the gonadotropin releasing hormone agonist. There are the antifibrinolytics. There are the non-steroidal anti-inflammatory agents. All of these drugs have their own modalities of actions that bring about alleviation of the symptoms. Now, let's get to the surgical aspect. The best treatment for fibroid is removal of the uterus. But again, in the course of evaluating the patient and knowing the patient's desire, one would know whether this patient should be counseled for hysterectomy, or is hysterectomy the best choice for her and her condition. And these are the questions to ask when offering hysterectomy, that is removal of the uterus. Hello, I want to be sure that I'm online. Hello, can I
Yes,
get
sir,
a
we can
feedback?
hear you.
Okay, thank you.
Good. Yes, sir.
And yes, like I was saying, before taking out the womb in women, one would want to ask, has this woman completed her family size? If she has one child, no child at all, or only one or two, and she's still desirous of having many, then hysterectomy may not be the surgical option of choice. But it's not just the woman's desire. There are many things that will be taken into consideration. What about what we might call comorbidities? That is, what is her health status, diabetes, hypertension, and others. So many of these will come into play. But if you are looking at family size alone, for a woman who has not attained the family size, you would not want to take out, one would not want to take out the womb. Again, has this woman attained, or is she attaining menopause? And are there multiple fibroids? If you look at the image on the right, for a woman that has this kind of fibroid, by the time you finish, she says she does not want the womb removed, that she only wants the fibroid removed. Looking at this image, by the time one would have done justice to remove most or all of these fibroids, what will be left of that uterus? Will it be functionally efficient to carry a pregnancy? It might even pose a risk to the woman in terms of bleeding. because for every cavity you remove the fibroid, one must ensure that that cavity is closed and there will not be bleeding into it. As later on in the presentation, we would see why it is somehow a difficult, not very difficult, but one needs to be strict in following guidelines and protocols to observe, to ensure that no bleeding would ensue after surgery. Because the number of patients that have undergone myomectomy, it's usually related to bleeding. So when a woman has, irrespective of her desire, look at this image, it will be difficult to have a functional, efficient womb left over. And in the interest of the woman's life, to preserve her life, avoid these complications, it may be wise, despite her desire, to have this womb taken out. So let's look at myomectomy. That is surgical removal of fibroids while preserving the uterus. This is for women that, yes, they want to preserve the uterus so that they can carry a baby, the pregnancy in future. In myomectomy, there are different approaches. The uppermost image there is what is called open surgery. That's the laparotomy, where you see it directly. Then the other two come under the classification of what is called minimally invasive surgery. Minimally invasive because there are little, what the knife on the skin is very minimal. And the two we have here are laparoscopy and hysteroscopy. In the middle image, except that it's not enlarged, you'll see instruments that are put through the abdominal wall into the abdomen. And if you look above, you'll see a monitor. So whereas they are operating inside under the abdomen, but they are monitoring with a camera, which is also inside the abdomen, is televising or showing on a monitor what is happening under the surface. The other category will be the hysteroscopy. These ones, the surgery, removal of the fibroid is done. That's the last image there, through equipment that pass through the vagina, the uterus, into the womb that will take out the fibroid. Now, all of these have their conditions because the patient for laparoscopy or for open surgery may not be suitable for laparoscopy. So there are conditions that help to identify which patients would have laparoscopy and which patients should have laparotomy, that is open surgery. Of course, if the fibroid is very big and massive, we will not be considering laparoscopy. Other forms of surgical treatment, these ones would, they will not take out the fibroids, but there are procedures that are done to cut off blood supply to the fibroid. And this is usually done radiologically guided, to such masses in the womb. The first we'll consider is uterine artery embolization. In this case, with radiologically guided catheters inserted, and directed towards the womb at particular fibroid masses, substances are injected. These substances are the things that will block the blood supply to that particular fibroid. And of course, when the fibroid is deprived of its blood supply, it will not disappear, but it will cease to grow and with time would shrink. But at least the potential for it to grow and for its symptoms to persist would have reduced. This uterine artery embolization is usually done for premenopausal women not desiring fertility. Postmenopausal patients that have had with failure with spontaneous regression would have this. But most importantly, uterine artery embolization is done for people that are not desiring fertility, or for people that surgery to remove the fibroid is an absolute contraindication. Another type of surgery would be uterine artery ligation. Fibroid surgery is a very bloody surgery. It's a bloody surgery, as I will explain later. So we have to take precautions to reduce blood loss. So uterine artery ligation is that which ties the blood vessel that supplies the uterus. If you see by the sides, you'll see the needles. There are vessels that come from the sides. So you want to tie these blood vessels to reduce blood supply to the uterus. And in so doing, you reduce the blood supply to the fibroids. And ultimately, it will reduce size, shrink it a little bit, and reduce the symptoms. Now, this procedure, that incision there is incision for cesarean section, because it is more commonly done to reduce blood loss, especially in women that maybe the uterus is not contracting. She continues to bleed after the baby has been taken out. So you tie the vessels to reduce blood supply, and by so doing, reduce blood loss. Other modalities, especially recent innovations, have been the use of high intensity focused ultrasound treatment. This uses ultrasound waves to shrink the fibroids. The ultrasound waves are converted to heat, usually under MRI. This is also done for people who have completed the family. What are the important precautions? Myomectomy or surgery is contraindicated in pregnancy. You would not, no one should attempt removal of uterine fibroids in pregnancy. It is not done. That is because the womb in pregnancy enlarges to much more than 10 to 20 times its size. And that is a muscle mass with blood flow. So any incision on the womb in pregnancy, it bleeds torrentially. So often, myomectomy or removal of fibroids is contraindicated in pregnancy. However, when someone may mention that she had removal of fibroid, if there is a fibroid that lies along the line of incision for cesarean section, of course, one will not be able to repair that incision, not until you take it out. So it's for those ones, you take it out, but one does not usually go for elective myomectomy. That is, you schedule to plan to take out the fibroids during cesarean section. It is not done. So for that reason, fibroid removal, myomectomy, is not recommended during cesarean section. And pregnant women with previous multiple myomectomies should be delivered by cesarean section to avoid the risk of uterine rupture. Now, there's a problem here because which also contributes to maternal death, especially for women, for some reason, because maybe they had a cesarean section before, or they had a myomectomy, they want to try vaginal delivery. It can be risky. It doesn't mean that a few may not escape it, but usually it will not be recommended that a woman that has had especially major surgery, major myomectomy, should be allowed to pass through, to undergo vaginal delivery. There is a high risk that the scar might rupture. A major limitation to all surgical and interventional therapies is that the incidence of fibroid recurrence is high, with new fibroid development occurring in almost 50% of persons within 5 years. So there is a tendency, people would say, Well, is it the old fibroid that has regrown? No, it's a new crop of masses that have developed. Is there any prevention for uterine fibroids? The answer is currently there is no way of preventing uterine fibroids. What are the complications of fibroids? Like it's at any point in time, before surgery, during surgery, and after surgery. Uterine fibroids have to do with heavy bleeding. So before the surgery, the complication might be blood loss that might lead to anemia. Uterine fibroids may be a risk factor for pregnancy loss, having miscarriages. But if the pregnancy manages to escape 28 weeks, it may be a reason, a cause of premature delivery. As the child is born long before 37 to 40 weeks. Another complication I had mentioned before might be the pain that occurs with women that have fibroids coexisting with pregnancy as a result of red degeneration. The fibroids, which will be competing with nutrients with the fetus, will deprive the nutrients and the whole body of the nutrients that would have been used to feed the whole body and the baby, and therefore the baby might come out smaller than that age or the size for that age. And by that, I mean the baby will have intrauterine growth restriction. Of course, if the fibroid, like I said, mentioned earlier, is lined within the inner layer, it's likely to impair fertility and therefore affect implantation, causing infertility. When a woman has fibroids and delivers, there's the risk of postpartum hemorrhage, which calls for attention by everyone involved in that woman's delivery, because fibroids impair the ability of the uterus, the womb, to contract very well and cut off the blood supply that comes from the womb towards the placenta. But where that does not happen, the blood vessels may be open, and this can cause torrential bleeding. Then the scar. So sometimes when we hear that a woman died of PPH, postpartum hemorrhage, there are many things that will cause postpartum hemorrhage. But if evaluated, there might have been something must have refused to, or must have caused the uterus not to contract adequately to prevent blood loss. Malpresentation, because of the masses in the womb, it may not allow the baby to take the natural position, which is the head down, buttocks up. So the baby may lie abnormally. We say this abnormal lie or malpresentation, which is an indication for cesarean section. And of course, if such a woman has had myomectomy is allowed to go into labor, she may have she may have her uterus rupture as a result of previous myomectomy scar. Now, this is one of the areas that we must pay particular attention as doctors and nurses preparing patients for surgery. It is very important that any patient and every patient must be adequately evaluated to know the baseline health status, especially to identify there might be other medical conditions that can worsen that patient's condition for surgery. So pre-op evaluation is very important, like how much has the patient lost? Does she even have enough blood? If she doesn't have enough blood, the priority might not be to take the patient to theater. It should be to transfuse this patient while giving medications that will stop, postpone, delay further bleeding, but buying time so that we can build up blood. And usually there are other conditions that we don't like when taking patients. Those conditions must be treated first, like hypertension, diabetes, etc. Also, if the woman is menstruating, we should take precautions not to do fibroid operations when the woman is menstruating, because we can cause a problem in future, which when we dislodge that part of the inner layer into the abdomen, These are the women that when they are menstruating and they are having pains, they may have, depending on where that tissue has been dislodged, she will probably be, in quotes, menstruating on that place. If it's on the urinary bladder, she might observe that when she's menstruating, making during that period, urinating will be a problem. If it is implanted on the scar, when she's menstruating, she'll be having scar tenderness and sometimes bleeding. So it is always advisable. Either we give drugs that will suspend, postpone the bleeding, or we don't do surgery at all during menstruation until the woman is dry. What are the precautions we'll take inside during the operation? We should plan ahead. One, it's very important, like I said, anything that has to do with fibroid is usually very bloody. So we must have transfused this woman or ensured that she has enough blood even before going to theater. Because if the woman does not have enough blood before going to theater and you take her to theater, and being a bloody operation, that woman may not leave theater alive. So there is the need to ensure that this woman's blood was optimal even before surgery. And intraoperatively, we must have made adequate preparations. That's why, depending on the size of the fibroid, we may ask for 3 or 4 units of blood. Then there are basic things, which these are standard precautions almost for every theater. There should be uninterrupted power supply. We should use the right equipment and not be managing equipment. And it's not just the surgeon that should be skilled, even the assistant, the nurse, everyone should be skilled so that everyone can identify anything that may go wrong during surgery. How about post-operatively? This is equally as critical as pre-op and intra-op. Because if something goes wrong and you have good team and good people, qualified people that will pick up, monitor, and identify the complications early enough, that woman still has a chance to survive and to live. But the general guideline is we must follow protocols and guidelines throughout in the management of patients before surgery, during surgery, and after surgery. Close every woman that has undergoing myomectomy, surgical operation, whether myomectomy, hysterectomy, or the other types of surgery, patients must be managed postoperatively very closely to detect early complications that may arise. Most women that suffer complications, it is possible that their monitoring was suspect. Because if a patient is well monitored, if there is a drain, usually because there's a risk of a woman bleeding, we leave a drain to collect blood in the abdomen. If a drain was not inserted and that woman is bleeding, how would one know? And if that woman, the drain is there, it should be monitored. How much blood is coming out through the drain? And is she making adequate urine? If she's not making adequate urine, why is she not making adequate urine? Then, at any time something goes wrong, it should be identified. Close monitoring would offer the patient the opportunity, for early intervention, and therefore one should call for help. If it's a junior officer, a junior nurse that is there, and something is identified early enough, call for help from the seniors so that with their experience and expertise, especially for patients bleeding, the earlier that patient is taken back to theater, the better. And not just hoping that, well, let's give it more time, it will stop. And even when the senior person identifies a problem, but is not sure and needs more time, he should also call for help because he's not the one that may sit down there to monitor the patient. But he needs to instruct the junior ones, the nurses, the junior doctors adequately and attentively on what it is he's looking at identifying so that there is room for early intervention. Then other things that should be done adequately and efficiently should be that fluids should be administered enough, the right antibiotics efficiently administered, likewise analgesics and drains. What are the harmful traditional practices that we have in this climate that will probably aggravate, worsen, probably a woman's chances of recovery or early intervention? Many people are known to administer abdominal massages in the hope that they will dislodge or shrink the fibroids. Rather, this may rather cause internal trauma to the woman, and after the massage, she may get home because the bleeding is not torrential. It might be mild. It might take 3, 4 days, 5 days, or even more, probably before this woman could get into serious complications. And often when they get into the hospital, it will never be disclosed that she had undergone such a process, which is what triggered that woman's downturn. Now, another sad thing is many women, because they want to avoid surgery, might collect toxic herbs, caustic substances to insert into the vagina with the hope that it will dissolve out the fibroid. But unfortunately, that rather introduces infection or it brings about chemical bonds. Um, Not quite 3 months ago, I had surgery for a woman who had large fibroid, but unfortunately, during vaginal examination, it could hardly take 5 centimeters of my little finger. All through when we took the history, she never disclosed that she had taken herbs. It wasn't until after surgery. So inserting toxic substances into the vagina would rather cause narrowing and shrinking of the vagina, and unfortunately, probably it worsen the woman's condition for future reproduction. Prolonged use of unregulated remedies. There were times in this city when people, especially, were going around hawking all sorts of substances. Unfortunately, no one knows the constitution of those chemical substances. A number of patients came down with kidney failure because they wanted to avoid surgery. And cultural conditions often lead women to want to normalize severe symptoms like heavy bleeding, painful periods, seeing it as every woman's silent struggle rather than a medical condition requiring attention. A number of women would do everything, especially when they have been told in the churches, you must avoid anything that has to do with operation using the knife. I have, and sometimes I'm successful in convincing such women, to change for a change of mind for early intervention. But unfortunately, some people are so ardent, and it is until their pastor says a word before they can do otherwise. If not, we have had encounters with those people, but unfortunately, by the time they get to us, the fibroid is too large. We can't even think of removing the fibroid alone. We have to remove the womb. So, fear of surgery-related deaths and the stigma of fibroid diagnosis often drives women to seek help from untrained traditional birth herbalists or prayer houses. Then some people, even when they know their abdomen is getting larger, instead of getting to the hospital, well, they claim and hold on to a fictitious pregnancy, that it's a pregnancy they would deliver. So what are these factors influencing traditional practices? As I have said, a lot border on sociocultural beliefs. Many people feel that losing their womb in this world, in the next world, they will not have a womb, and therefore any alternative to preserve the womb, they will take that. But unfortunately, it ends with dire consequences. Economic barriers. The high cost and poor access to orthodox healthcare push many women into what may be seen as affordable, but unfortunately, these are fraught with complications. Even the myomectomy and hysterectomy we are talking about, not alone those highfalutin procedures like laparoscopy. Do we have the resources? Do we have the experience? Do we have the equipment? How many of these facilities are here? So even those ones are usually prohibitive and exorbitant. Many women cannot afford these other ones, even in government hospitals. So it will not be surprising that they'll tend towards traditional options to avoid surgery. And unfortunately, a number of women are not even aware that they may have these significant misconceptions about the causes and effective treatments for fibroids persist. And this may lead many people to using over-the-counter drugs that may inadvertently promote fibroid growth rather than reduce it. A number of supplements are, in the pharmacies, and people will take them. And when they ask me, what about these supplements? I tell them, what I know is the one that can give them relief within almost immediately. But as for these ones, what is the duration? Are you going to take it? And most people feel that taking supplements for 1 week, 2 weeks, they should notice symptoms. And I tell them, if supplements are beneficial, can you take them for months? Would you want to do that? And at the end, these supplements are not even cheap. If you put the cost of supplements for about 5, 6 months together, it's enough to take out or to undergo surgery. What are the frequently asked questions? Will having fibroids prevent me from getting pregnant? Well, maybe not necessarily. Many women with fibroids conceive normally. However, as had earlier been mentioned, those ones probably with submucosal fibroids may affect implantation and therefore affect fertility. So patients' treatment will have to be, women with fibroids, the treatment will have to be individualized. We cannot extrapolate one woman's condition with fibroid to another. Do I need surgery to remove them? Only if they are symptomatic. And again, treatment would have to be individualized depending on the size, the location, the symptoms, and fertility goals. Can fibroids grow back after surgery? Yes. Myomectomy surgery only removes the existing fibroids but does not prevent new ones from developing, or those tiny ones that were there but were missed during surgery. Having packaged, listened to all of this, what can we make out about uterine fibroids, living with fibroids? In conclusion, I would say uterine fibroids are the most common pelvic tumors and can affect up to 80% of women or persons with a uterus. Of course, these are women during their lifetime. And though most are asymptomatic, that is not causing symptoms, the few that cause symptoms can cause significant problems, including anemia, infertility, and obstetric. By that, I mean pregnancy and labor complications. Management has to be tailored to patients' symptoms. In number, women, this will probably have to be emphasized over and over so that they do not extrapolate one person's symptoms or treatments to their own symptoms. So management has to be individualized, tailored to symptoms, fertility desire, and fibroid characteristics. Medical therapy only provides temporary symptomatic relief. Surgery is the definitive treatment, especially hysterectomy, which is the removal of the womb. Harmful traditional practices remain a significant barrier to timely and effective medical intervention and care. And lastly, awareness, early diagnosis, and evidence-based management are key to improving patient outcomes. In climes where women's education enlightenment is high, there's the probability that also the health care and awareness benefits to women will be larger than in places where health awareness, education of the female gender is low. Having said this, well, ladies, and for the men that may be on the forum, I'm not aware, I'd like to say a big thank you, which in my language is pronounced soso. Thank you for the audience.
Thank you so much, Doctor, for this wonderful presentation. If you have been well educated on fibroids, let me see your comments. Let me see your comments. Put out your best emoji to encourage Doctor. He has done so well for the past 50 minutes. We've been listening to him. It's been a wonderful session. Let's see your reactions on the comments. If you've been following, let's see your reactions. Are we there? Okay, someone says thank you so much. Okay, let's keep them coming. Let's keep them coming. All right, thank you so much, Doctor, for breaking this down for us. I mean, this has been a lot to take in. And from my end, I've been so scared about, just talking about fibroid. But now that you've broken this down for me, I think I totally understand it now. And it's going to be time for questions and answers real quick because we've been on the call for a long time. So if you have questions, for Doctor, please put them in the comments right now. But I'll go first. Let me just ask my own question before we start taking questions. But I see some questions already in the comments. So, Doc, I heard you say that when we should actually let sleeping dogs lie. Maybe if it's not painful or causing excessive bleeding, we could just, for the meantime, let it be till it starts, disturbing and all. But the question I have is this: what if the stomach just starts swelling as a result of the fact that you've been actually diagnosed with uterine fibroid? Is it something to be worried about? Is it something to start getting scared, or you can just let it go as it is, growing as much?
Yes, thank you. That's a symptom already. It's causing a disfiguration in one's body, the abdomen. It's embarrassing going around and people are asking you, are you pregnant? I mean, probably one is desirous. So the fact that it has disfigured someone is a symptom. So you cannot say at that stage it has become significant so that it should be attended to.
All right. Thank you so much, Doctor, for answering my question. So just before we go into the questions and answer session, please, you can see your screen. We have our handles displayed on the screen. Please follow our handles, follow the work that we do. Also, we would like to hear your feedback about today's program. Let's hear what you've learned so far. Let's hear what you want us to improve. Let's hear you talk about the session through the feedback link that is going to be posted or is already posted on the comments right now. Just help us engage in that as well. So I'm just going to take questions as I see them coming in. Let me go. Okay. All right. So we have a first question from Alexander Florence. She says, what brings about difficulties in conception after the surgery?
That's a very technical question. How do we ascertain that the conception challenge may not have been there before surgery? Because there are women that wanted to conceive, were being evaluated, but probably did not have the amount to go all out. But by the time comparing when they presented and when they have returned with resources, fibroids that were not there, you now have fibroids. Would you now say these fibroids were responsible all the time when they were not there? And but we know fibroids, especially removal of the submucous fibroids, they enhance the chances of favorable conception. One, two, even when we say we do surgery, where was the fibroid located? If the fibroid was located close to the tubes, in the course of incision and repair, even the healing process may interfere with the quality of the tubes. So, and again, when we take out along it will be assumed that when you take out the fibroids, there should be improvement, but no one can tell. Most important thing is there are many women who don't have fibroids and are able to conceive. So we can say there is an association between fibroids and infertility. But it may be difficult to, especially for those that may not be submucous, you may not necessarily say that the fibroid is particularly responsible. But when evaluating women to help them get pregnant, whatever it is, what risk factor stands along the way, it is best to improve the woman's chance, do what is needful, remove the fibroid, any other thing. But after surgery, a number of women are fortunate, they get pregnant. Some, unfortunately, may not. But this is where I want to say some women, even without fibroid, didn't get pregnant. So you may not particularly say that the fibroid or the fibroid is responsible. Even the surgery may be responsible.
All right, thank you so much, Doctor, for that response. I hope Doctor has been able to do justice to your question, Alexander Florence, and thank you so much for engaging with us. We have another question here, and just because of time, we'll just take at least 5 questions so that Doctor is not too exhausted from answering too many questions. But our forms are open for you to drop your questions, and Doctor will do justice to that and will also follow up with responding to you. So the second question is from David Gloria. She says, I heard you mention cancerous fibroids, but from the definition of fibroids, they are non-cancerous growths. Can you explain more, please?
Yes, thank you. I did say that fibroids are non-cancerous tumors of the womb. But very occasionally, and I saw the statistics, one said about 1 in 100,000, there's the risk that the fibroid may undergo a transformation to become cancerous. But if you see 1 in 100,000, that's almost very rare. And that is why I said investigation like MRI is not the traditional modality for evaluating, but probably when there is confusion and you need a higher level of evaluation to make this distinction, then MRI, which is over 150,000, whereas scan in most places shouldn't be more than 15,000. So why would you recommend the patient for an investigation which is over 200,000, 150 to 200,000, when 15,000 can do it? So those high-level investigations are reserved for additional information. But I did not say that fibroids are non-cancerous, but there is very remote probability. Let it just be in the knowledge that there is a possibility like that, which is 1 in 100,000. Thank you.
All right, thank you so much, Doctor. So we're taking 4 more questions. We've already had 2. There's one from Mary Ann Intikora. She says, you mentioned earlier that some hormones are responsible for this. Is there any lifestyle factor that can prevent or manage this, like diets?
I had mentioned earlier in the presentation, well, there are 2 things here. Hormones, female hormones are estrogen and progesterone. We all know that. So, but as the woman approaches menopause, when these hormones start declining, that is when also it is observed the incidence fibroids, the symptoms also starts abating, because this estrogen and progesterone, so to speak, like feed these tumors. So when menopause approaches, it is likely that there might be improvement in symptoms. Then what are the lifestyle factors that can help prevent, manage this? Well, like I said before, it's been documented, like diets like red meat and ham and all of that have the potential to increase fibroids. And they say So are you going to stay away from meat? But remember, the argument can be for or against because fibroids occur more commonly in blacks. So even if you get to the villages where socioeconomic factors will not allow them, to have the quality of nutrition with red meat, is it red meat that is also causing those people to have? But it's been known that in the last few decades, there's been an increase, and of course, that would be probably because of better feeding amongst the women. So it is something that you can argue for, you can argue against, but the lifestyle, it is also said that, well, exercise and all of that may reduce. And these are from studies, but studies that are associated means that if you group people together, there appears to be some benefit. But whether you recommend these benefits to everybody, it's another thing. But it's been observed that a number of women that are athletes, the risk is low.
Okay. Thank you so much, Doctor. I hope Doctor has been able to do justice to your question as well. So we have a few more questions here, but I'm taking just three. The next question says, I had an open myomectomy in 2020, hysteroscopy, one in February and the other one recently in April due to submucosal fibroid. I am currently on my period with heavy bleeding. So I don't know if that's a question, but
Yes, yes. The fact that you're having recurrence means that the myomectomy in 2020, took care of the existing fibroids then. And after that, you have developed fibroids, and unfortunately, in places where would cause symptoms. Now, it's difficult because even with hysteroscopy, it's very technically challenging. What will be the size? I have a few patients that ultrasound will diagnose uterine fibroids, but they are close to the inner lining called endometrium. Is it because of this tiny fibroid you will now subject this patient to open surgery, myomectomy? And what is the guarantee that if you go through the vagina, you'll be able to remove this fibroid? So it's unfortunate, it's typically challenging. So I wouldn't want to blame the doctors, neither would I want to say, well, for you that you have it, the fibroids will not seek your consent where they should be. They can be anywhere, and we at most can only do our best, but it's an interplay of several variables. I'm sorry, it might be difficult to say what exactly precisely, but if it becomes life threatening, what will be recommended will be to take out the womb, and you have alternatives of having a child.
all right. Thank you so much, sir. And thank you for sharing that with us. I know that's actually something very vulnerable, but thank you for the courage to share that with us and get answers to your questions. So we have a few more questions here. And the other person says, Adenike Ayo Ade says, why do I always have pain in my lower abdomen?
There are a number of variables, and I would just like to say you have chronic pelvic pain. Is it from previous badly treated? Chronic pelvic pain means something probably had happened. Is it as a result of endometriosis? Is it as a result of adenomyosis? Is it as a result of previous PID? There are several variables. And I cannot sit down here with insufficient history, examination, and investigations to tell you what could be. But I'm going to recommend you to a gynecologist, a good gynecologist that would evaluate. And sometimes, unfortunately, at the end, we may still not be able to arrive at a diagnosis. And chronic pelvic pain might be because the pelvis is frozen. What will be the cause of frozen pelvis? I have gone in, patient complained of surgery, we went in for a cyst excision, but in getting there, we saw that the pelvic structures were all matted together and there was nothing we could do. We closed up and came out. So I'm going to recommend, please see a gynecologist. Thank you.
Thank you so much, doctor. Please see a gynecologist. That's the next. So the next question is from Inusa Makpang, and he says, please, sir, about the numerous things women are inserting in the vagina, especially young girls, help us share more light on the effects.
I wish I know why it is, for what reason, what purpose people are inserting things into the vagina. What do they hope to achieve? Because it might be ignorance, they are unaware of the consequences and the complications that could arise. What do they desire? If they are inserting medications, because there are some medications that come as pessaries. Oh, fine. That's like canesten to treat candida. That's okay. But if it is not orthodox medicine and probably for dissolving anything, well, let me say that I may not sit down here and speak emphatically as almighty knowing, or maybe there are innovations that have come out I'm not aware, but I'm going to recommend, please, when anyone is asked to insert anything, if it is administered by the gynecologist, such a person should ask what it is and why. But any other thing may cause burns or may introduce infection and would further destroy the reproductive potential of the woman. So, except I know what it is and the indication why that person is inserted and who gave that thing to be inserted, a native, a herbal doctor, it's a no-no.
Okay. Thank you so much, doctor. It's a no. Don't insert anything except prescribed or recommended by a doctor. Okay. Thank you so much, sir. Our next question is from Omole Wami. I don't know how to pronounce the other name, but he says, I would like to ask if fibroids can be infected and causes pain in the belly button.
These are two separate things. Don't put them together. Pain in the belly button can have its own barrage of causes, and infected fibroids, I did say it like probably might be related to pregnancy, maybe when the baby is out, a miscarriage or preterm labor. There must be something that probably would maybe introduce the infection, or an IUCD is introduced, or in fact, even sexually transmitted infection. It can cause the fibroid to be infected. That it has its symptoms. Infections will generally cause discharge, fever, pain, and other things. And for which pain in the belly button might just be one. But belly button pain, if I'm taking a history, when do you have the belly button pain? Do you even have a fibroid? There are many people that have belly button pains and don't have fibroid. So you don't have to adduce the, what is it? The fibroid. What is the size? How did you know it's infected? Again, the best bet is see a gynecologist.
All right. Thank you so much, doctor. I've just gone through the comment session, and I think that's the last question from our participants for today. But I'm hoping that when filling out the feedback forms, they would also still highlight possible questions that they might have or they might need clarification on. So thank you so much, doctor, for taking our time.
Please, may I
Okay.
give a remark?
Absolutely.
Some conditions are hardly preventable. And especially because things like this can occur and one is not aware. I'm going to recommend that women generally should have maybe once yearly medical evaluation, especially scanning in the pelvis. It would help, diagnose or pick up any abnormality, like if there's a fibroid. And even if there's a fibroid, doesn't necessarily mean it's going to be symptomatic.
Okay.
And women should also, once in a, there are recommendations for pap smear. They should also do that. And having a once yearly scan, would also help to reassure the woman that her pelvis, to a large extent, it's excluded from problems. So I recommend regular pap smear to screen for cancer of the cervix, maybe also, but even if you do regular scan, it will only give an idea that, you know, there might be something and there might be nothing. And even if there is something, it doesn't necessarily mean that it's symptomatic. But I'm going to recommend that women should have yearly routine medical exams. It will go a long way to ensuring their reproductive health. Thank you.
Thank you so much, doctor. That recommendation was really needed because most people just neglect their bodies and just wait for things to happen before they are even, more informed. So thank you so much for that. We have another question that just dropped from Progress Sanita. She says, "Doctor, can taking of fruits like orange, mango, and banana make fibroid to grow bigger due to its surgery nature? Its sugary nature, rather."
I'm sure AI may not even be able to answer that question because AI has its obstetrics, herbal medicine, native medicine. I'm orthodox, I'm not a dietitian, so it will be difficult. I'm sorry, as it maybe the dietitians, or those ones that have in this specialty may have an idea as per what dietary input may help to reduce and maybe aggravate fibroids. But permit me to say that I'm sorry, as an Orthodox doctor, I am not informed or aware of these ones. You could probably seek this information from dietitians or the relevant specialty. Thank you.
All right. Thank you so much, Doctor. This has been enlightening. And just to highlight some of the things that you actually said, you talked about awareness and early diagnosis and also evidence based management. Those are the key to improving reproductive health. Thank you so much. And the fallback of fibroid management as submitted by Dr. Idorain Udo at the major thematics of the Agatha Valentine Hope Foundation. So please stay tuned to all our channels, all our everything that we have learned today would also be repeated on our on the handles that have been shared in the comments. So please do not hesitate to follow us and also do not hesitate to fill the feedback form so that we know that this has been really insightful and impactful for everybody on the live program. So as we gradually come to the end of today's webinar, I would like to, on behalf of AVHF, say thank you to Doctor for taking our time out of his very busy schedule to be here with us. We don't take it for granted. Thank you so much for answering our questions. Thank you very much, Doctor. And I would also like to say thank you to our founder and our executive director for the leadership of AVHF. Without you, we probably not be having this very important conversation. So thank you so much. And also just to highlight our partners in mobilization on this particular webinar, we give accolades to Mentor, and we also say thank you to Coral Wellness, and we also say thank you to um, the we say thank you to the last of our partners in mobilization. I can't see the name here, but yes, thank you so much for being there for us as well. And lastly, we say thank you to every participant on this program. We will not be having this conversation if you did not even follow up from the beginning to this very moment. So thank you for being here. Thank you for engaging us. Thank you for participating actively to the success of this program. So having said this, we have come to the end of this program, but I will still highlight very, very specifically that you remain in the community, because there will be so many updates going on there, so many programs that are coming up. So you wouldn't want to miss that. It's very important that you stay in the community, and we would actually love to see you there very actively. So thank you so much, and we remain committed to creating access to equitable health, reproductive health services for women and girls all over the world. Thank you so much. And my name is Grace Udier, and it was an honor to host this webinar. See you next time. Thank you so much.